You guys are loaded, huh?
Yes, sir.
Okay, maybe we'll start with. Sure. Let one of them start.
Okay, sir.
Getting delayed. Should have loaded before, man. Not at 8 o'clock. Huh? Come. We'll start recording. Started, huh? Okay. They had some internet problem. Okay, good morning, all. Welcome to this clinical meeting today. Thank you to all the PGs who have made the presentations and to those who are logging on. As usual, at the end of history and physical, I'll ask the PGs to wait and we'll have a discussion of the differential diagnosis and then we'll proceed. So with that, I'll hand over to Adarsh to start.
Good morning. The topic is the proctological dilemma presenting on behalf of Medicine 3. It's a 36-year-old Mrs. S. Yes.
No. The image out. Camera our man.
36-year-old Mrs. Shalini, G2 P1 L1 at 16 plus 5 weeks of gestation, presented with history of loose stools for 4 days. It was small volume, watery, with blood. There was no abdominal pain, no vomiting, no fever. She also gives history of this bleeding PR for the last 2 years, and this was on and off. And it was not associated with increased stool frequency, and there was no hard stools associated with the bleeding PR. And she also gives history of a hemorrhagectomy done outside in 2019. General examination, she was tachycardic and blood pressures are normal, and otherwise there was no other alarms, and systemic examination was within normal limits. So at this point, I just want to ask what's everyone's differential diagnosis. It's as of now, it's a 4-day history of increased stool frequency with blood present.
Yeah. Can you put your differentials in? There's be a link for the Slido?
Yes, sir. Sorry. Oh, sorry.
Okay, so we'll give the audience 1 minute to give your differential diagnosis. All managed? Okay, another 10 seconds. Okay, at this point.
So yes, so these are the differentials we initially considered. A dysentery was the first differential because it was increased stool frequency with blood. An acute presentation of IBD possible, but again, little atypical. And then so that's what our first presentation of the patient was. Now, and if you look at the investigation, it's a microcytic hypochromic anemia. And yes, she has been having this increased occasional bleeding, and there was a history of hemorrhagectomy in 2019. So now the question is that all this case is about? But now there are certain few caveats. One is this patient has occasional bleeding PR, and this was not associated with hard stools and there was no increased stool frequency. So IBD is ruled out. It was not associated with hard stools. So usually piles does not have it when it's soft. So those differences ruled out. And next is the mother had history of CA colon. And so the acute presentation of 4 days, that might have just been an acute gastroenteritis. But then this pressing history of intermittent blood-stained stools and the mother having a CA colon. So now the next thing, what do you do next? She's pregnant and she's come with this acute syndrome of an acute gastroenteritis. The bleeding PR wasn't so much, but acute gastroenteritis. And do we attribute the bleeding PR to just hemorrhoids? And the iron deficiency anemia is also there. She's a woman. And she's had hemorrhoids and she might have some nutritional component. So is that it? And do we not evaluate her further? Or because there's this history of malignancy in the family with this bleeding PR, which is not really fitting with the overall syndrome, do we evaluate further? So that was a dilemma at this moment. So at this point, we actually went ahead and evaluated further. So now what we did is we did a PR, that is the cheapest test, and that showed a rectal mass. So then we called surgery for a proctoscopy, and this showed two growths, one in the anteriorly, and there's another polyp also in the anal verge, and a biopsy was taken. So now we look at colorectal polyps. So this can be neoplastic, hematomatous, hyperplastic, or inflammatory. And why are polyps so important? Why are all polyps removed? Because all polyps have a malignant transformation change, and this is the pathogenesis change of polyps. So our biopsy report showed a tubulovillous lesion, which is a high-grade dysplasia. And then CA was down to 380. Next, you look at pregnancy and CA. Is CA elevated in pregnancy? But it isn't. Or there's a slight elevation, not 380, which is extremely high. So we have a patient who has come with bleeding PR, with the lesion PR, with a polyp and high CA. But the first biopsy which was done did not show malignancy, but showed tubulovillous lesion that is in the spectrum of adenomas with high-grade dysplasia. So at this time was whether to stop, and that could be the cause of bleeding PR, or whether to evaluate. Thing is, because she was in the second trimester, we didn't want to put any undue stress, and so finally we went ahead with only a proctosigmoidoscopy, and this showed multiple polyps in the rectal region with an ulceroproliferative mass, and that's what you see in the bottom 2, 3, and 4th picture. That is ulceroproliferative growth, and that's when we did the biopsy of this, and that confirmed adenocarcinoma of the rectum. And then after this, an MRI was done, which showed there was a CA rectum and there was mets to the liver, bone, and local infiltration. But she had no other symptoms apart from this presenting complaint. So finally, impression was that of a G2P1L1 at 16 plus 5 weeks coming with a metastatic CA rectum. So there were 3 points I wanted to highlight. One is colonoscopy in pregnancy. Second is screening of CA rectum. And third is CA rectum in pregnancy. So the first one is colonoscopies in pregnancy. The title is wrong. It's colonoscopy screenings. So, and one is colonoscopy in pregnancy. So one is, can we do colonoscopies in pregnant women? It's actually it's a procedure that is not usually done. If you're doing it, it's best done in the second trimester. And generally, while maneuvering the colonoscope, at points you increase the pressure, given pressure. So when you do that, make sure it's not aimed at the uterus. And second, you have to avoid a lateral decubitus or a prone positioning. And bowel preps are not studied adequately. The largest actually, it was they took a cohort of 20 patients who had to undergo colonoscopy, and it was the indications for one was persistent diarrhea, hematochezia, abdominal pain, which was very severe. These were the indications that were taken, and the timings, most of it were done in the 62nd trimester. So they found that actually there was no adverse fetal outcomes if it was done in trained hands. And there were only 2 mild transient complications of hypotension, which did not cause any persistent or long-term adverse outcomes. So even though it's a procedure that we all deem contraindicated in pregnancy, it can actually be done if the initial index of suspicion is very high and there is a change in management that can be given post diagnosis. It can be offered to patients. The second is a screening for CA rectum. So this is there a role of screening patients? So the use of screening patients not to pick up and increase the number of cases, but will that create a mortality benefit, or will that improve by early screening and early diagnosis? So the rationale for this comes from the linear evolution model, which shows that when the polyp starts growing, and these are because of multiple mutation checkpoint inhibitors that might have been mutated. So if the APC, which is a tumor suppressor, gets mutated, or the KRAS or the P53, and this leads to a polyp growing, becoming carcinoma. Again, this is not an immediate process, but it takes time. So this is what this shows. So this is why every polyp needs to be biopsied and looked at. So screening a CA rectum, when it was actually first put forward by the US Preventive Service Task Force, and now the largest, they did a systemic analysis in 2021, and this showed one is screening reduced risk of mortality. Second is the modality of screening, the best is with colonoscopy. Next is CT colonography, and the third is a fecal immunohistochemistry test. FIT. And occult bloods, though used in our country, is not really used in is not really approved by the FDA for this. And finally, harm. The harm is that around the study actually studied around 5,500,000 citizens, and in that the serious harm was only seen in 26 to 30 of the population. So it is very, very low. So next is, what is the recommended screening? So that is, all patients, they start screening at the age of 45, and there are various modalities. The best again is colonoscopy. But for our, so now our patient who had a first degree family member with colorectal carcinoma, the age of screening should actually start at 40 or 10 years before the diagnosis of the cancer in the family member. Second is we have Lynch syndrome. So that is when you have a defect in the mismatch repair, and so those patients have a predisposition for malignancies, and that should start at a much earlier age, at the age of 20 or 2 to 5 years before the earliest age member in the family developed the cancer. And the intervals colonoscopies are much more frequent. So finally, CA rectum in pregnancy, is it common? It's not it's a very, very rare entity. Usually seen at the age of 31. When they studied, so what they did in this study was they sent an email to all cases, might have been missed, but they sent an email to all the colorectal surgeons and the patients dealing with colorectal malignancies, the oncologists, and they've asked them the cohort of patients who were pregnant and if they had any patients. So based on the replies they got, they found the mean age was 31, and the treatment, which is best expert opinion, is if the patient is less than 20 weeks, is to go ahead with surgery. But if the patient is more than 20 weeks, is to plan early delivery based on the country's like how equipped they are to handle, at what week of gestation they are equipped to handle delivery. So plan for early delivery and then surgery. If surgery is not possible, that's in our patient. So ideal therapy for CA rectum would be a neoadjuvant with FOLFIRINOX, followed by surgery with RT, and then completion of adjuvant chemotherapy. But oxaliplatin and 5FU are class D. So these can be used, but there is risk in pregnancy. And so for our patient, which is a metastatic CA rectum, we did one is a KRAS mutation, and we started the patient on capecitabine and bevacizumab. This decision is finally made by medical oncology as to the treatment regimen, and now the patient is under medical oncology for treatment, and the patient was not actually willing for termination, so the pregnancy is being continued. Thank you.
So Adarsh, next time a pregnant lady has bleeding PR, would you recommend sigmoidoscopy if the PR is normal?
If the PR is normal, sir. So if the bleeding is not characteristic of an anal fissure or a hemorrhoids, and there is family history, then yes, sir, at least proctoscopy and sigmoidoscopy.
Yeah, otherwise, whereas hemorrhoids are common in pregnancy for many women. So bleeding PR may not be that unusual in pregnancy.
Yes, sir.
So we must be careful that we shouldn't overdo sigmoidoscopy and all of them.
Yes, sir.
What would you say was the clue that made you do that?
So one herring that was the fact that she said she had a hemorrhoidectomy, so we thought it's all because of that. But the fact that the bleeding was not typical of a internal hemorrhoids kind of bleeding was one thing that stood out, sir.
And the family history.
And the family history of first degree relatives.
Did this lady fit into any syndrome? Because her mother had colon cancer.
Yes, sir.
She has colon cancer. Did you look for a syndrome?
So we didn't. We actually, in the biopsy block, there was no MSI high, so it was less likely to be a Lynch something, so Lynch syndrome.
Excellent. Any questions?
When did you make the decision to continue the pregnancy?
So, ma'am, that was made after the diagnosis and explaining the prognosis to the family member. with medical oncology and OG, we spoke to the family and we counseled them actually for termination, but they were very adamant that they wanted to continue the pregnancy.
Actually, ma'am, there was an MDT that we had between surgery, medical oncology and us. So she, by the time she came, was very, very frail and wasn't really, even a 17-week uterus is difficult for her to hold and sit for a long period of time. So while we did discuss termination with her, we felt that even that, because her previous surgery, her previous pregnancy, which was 4 years ago, was an LSCS. So even terminating, she may not have been able to, she wouldn't have been able to expel normally. She would have had to have a cesarean section for that. She may not have been able to tolerate even that surgical procedure. So the decision after the MPA that was being made was that we would disregard the fetus at this point, treat her, and release. So that is what the plan. I mean, it's a palliative. We're giving a palliative chemo at this point because she may not tolerate the chemotherapy at full dose right now because she is very frail and she has lipomats and she may not survive the malignancy that she has at the stage that we unfortunately picked up at. Because when we did the flexible sigma, it's extending from 3 centimeters from the end up to 20. So it's not a small tumor. And it's multiple nuts in the liver, it's not one. So the plan made at that point was to disregard the fetus, give her for 3 months, start the chemo, and then we take it from there and see how long she survives.
The family history didn't come out at the start. We had asked them family history and they said no. But we noticed that the mother had
Colostomy, which we
and then we asked, they said, yeah, she had some.
There may be some sort of a syndrome because mother having, she having.
Yes, sir.
She should have required early screening from 25.
Okay, because we started late, we'll have to rush a bit. So we'll thank you, Adarsh. Well done.
Thank
Have the next presenter. Come. David.